finally, a source of raw, real, and honest information on healthcare issues that matter most. Welcome to BS Free MD. From the latest medical information to how to stay sane as a doctor or a patient, no subject is taboo, no BS is allowed. Now, let's welcome your hosts, Doctors May and Tim Hindmarsh.
Hey everybody, welcome back this week. We have a fresh episode of The Doctor is Patient. We haven't had one in a while, and this is going to be, you're going to love it, I should say. Our guest today is Dr. Annie Thurman. She's a gynecologist, and she is in Virginia, and she so graciously agreed to come on our show and talk about her experience about being a patient instead of the doctor. I will say that she's got a very interesting perspective on what it was like and what she went through and how she's used that to go forward, and how she looks at patients going through things. And it's really refreshing just to hear her story. Any thoughts, Tim?
Yeah, I mean, she's incredibly positive, which is what we need, especially nowadays. And, you know, as we've talked about before, we're trying to feature positive things and specifically courage, because at least my biggest complaint of the last 2 years has been a utter lack of courage in leadership and in our chosen profession. So it's awesome to talk to people that are courageous and have lived life and gone through things and come out with a great attitude. And that's definitely Dr. Thurman. That's for sure.
Absolutely. All right. Hang on as we get into the interview. Super excited to have our guest with us here today and hear her story. Welcome, Dr. Annie Thurman. Thanks for being on our show.
Thank you for having me. I'm excited.
So tell us and our listeners, just give us a little background about your specialty, your training background, where you're at, and what you do.
Sure. So I'm an OBGYN physician. I'm originally a Midwesterner. I trained at the University of Chicago, and I had the military, the Navy pay for my medical school. So I did my residency at Bethesda Naval, and then to pay off my military scholarship, I was in Japan for 3 years, which was wonderful. And then I came back to Bethesda, and I met my husband in Japan. He then went to medical school 12 years after I went to medical school. So we were down in Charleston for his medical school. He's a military, so we were out in Texas for his residency, and I've landed here in Virginia 13 years ago. I primarily do GYN research. I work for a division of the department called Conrad, and we do HIV prevention research. We do contraceptive research. We've branched a little bit into prevention of breast cancer, prevention of preterm labor. But I think the main thing that having this illness taught me, and just, I don't know, getting older and stuff, is I feel like I'm a better doctor because I've had all this crap happen to me. And, when I was attending, I was like 30 and I was single, and, so I guess life makes you a better doctor.
Yeah, all the challenges you go through, but I think you're right. For like myself included, being a patient a lot of times, I'm a patient all the time. And those of us that have gone through things, it really being on the other side of the table is really humbling and opens your eyes to things, for sure. So thanks for, I always thank our veterans and people in the military. We have a special place in our heart for those people. And so thank you for your service. We have military in our family.
Yes, he was just trying to call us a little while ago.
Yeah.
So
awesome.
It's either news about his schooling or he needs money for a project of some kind. So
I'm betting it's money anyway. So
the military is a good place to get money for schooling. So that's good.
Exactly. He wants to make a career of it so far.
Well, he's done very well. There's no way we would have paid for what his education would have cost.
well.
Oh my God.
It
Yeah,
was just,
for
it
sure.
Well,
was
we
crazy.
could have. We had to sell some of your cars, Tim.
That's one of the non-negotiables.
Anyways,
So
so
this is not about me.
yeah, I was going to say, so let's change it here. Why don't you, so tell us about your story as a patient and when did that begin and what happened?
Sure. So 2019 was the worst year of my life, and not just because of breast cancer, but so I had a mammogram in February of 2019 at the regular place. I was getting them every year. I was 51 at the time. And I remember I was in the operating room right after I had my mammogram, and they called me saying, oh, we need you to come back in and get some additional views. And I'd had that happen once before, so I was like trying not to stress about it. So I went back a couple days later, and I'm getting all of this stuff done at I work at this hospital called Sentara Norfolk General. We're the teaching hospital for Eastern Virginia Med School, and so I had all my care at Sentara. So I went back in and got the additional views, and the radiologist said, we see calcifications, so we think you need a biopsy, right? So I was kind of bummed about that. Um, and
Yeah.
then, do you want me to tell you about the biopsy?
Yeah,
Absolutely.
yeah.
So I have to preface this by, so the research group that I'm working with, we are developing some like contraceptive implants, like Norplant and Nexplanon, right? And we're doing a lot of work with this human-centered design firm, industrial design firm, making trocars, right, to put these implants in. And the typical Norplant or Nexplanon inserter is a 10 gauge needle, which is it's a pretty big needle, right?
Yes, for our non-medical people, those are, I'm trying to think of a diameter to compare it
Actually,
to, but
it's about 3 millimeter diameter.
right.
You know,
It's
and
big.
So if
so
you pull
why
out
we're-
the ink cartridge in a Bic pen, it's
yeah,
a little bit bigger
maybe
than that.
Yeah, bigger than that. Yeah.
Yeah.
But so I went over to get this biopsy done, and uh, my mom had breast cancer, and they missed it. So I was telling the on the biopsy they missed it, and I was telling the radiologist, like, hey, my mom told me that I needed to tell you about this. And he said, okay, well, what we'll do is when we get the core biopsy, we actually image it, and we make sure that there are those calcifications inside the biopsy, the piece of tissue. So anyway, so I have this biopsy, and the radiologist has me come over and look at the core tissue. And it was like, wow, that's a really big piece of tissue. I'm like, how big of a needle is that? And he goes, oh, it's a 9 gauge, which is slightly bigger than like the 10 gauge needles that we were talking about at work, So like, whenever we would have discussions about, the 10 gauge needle and is it painful and blah, blah. I've never had like a Nexplanon or a Norplant, but I'm like, well, I can tell you what it feels like to get a 9 gauge needle in your boob.
There you go. Exactly. Been there, done that. I've one-upped you.
Been there, yeah.
I've only had that for my my little barbells and my nipples.
Oh,
so
shush.
I think
Yes, right. What was going through your, if you don't mind me interrupting this, take us to that moment. What was going through your head when they were doing the biopsy? Because you just said your mom had this and they missed it. Are you thinking of that, or you're thinking more about work and oh my gosh, this thing's the size of what I use at work?
Yeah, well, I didn't know the needle was that big until afterward, and I just remember thinking like, "Oh, this is going to suck. This is going to be painful," and it wasn't that painful. And they were telling me like, "Oh, only 10% of people that have calcifications actually have breast cancer." So I was like, "Okay, the odds are that this isn't breast cancer." So I was still pretty, chill about it. But my mom. She had her care at Northwestern all her life, and they thought she had breast cancer on a mammogram. and she was retiring and moving. And so she had her biopsy done at like another location, like in another state at an academic place. And then they said, oh, everything's okay, and followed her for a couple of years. And then my parents moved back to Chicago, and she went back to her OB, who's like a friend of mine. And her friend was like, you still have breast cancer, you know? So,
Oh.
I mean, that was, and she did. And she's fine, you know, but, yeah, I was worried. I needed to tell the radiologist, like, hey, you know, my mom went to a very reputable academic center and they still missed it. And I didn't realize that they looked at the calcifications underneath the, you know, they imaged the biopsy so that you could see the little calcification.
Mm-hmm.
So I knew that they got it, you know, they got the calcifications. And it took like, it really took a long time because I guess my breast cancer was really deep, almost like on my chest wall, you know. And I remember after I had the biopsy, I went out with one of my buddies. She's a family practice doc, and she and I met on the flight to Japan when we were both Navy docs. So we met in like 1998. She lives in the area. So we went out to lunch after the biopsy, and I was like, yeah, it was really sore. It took them a really long time to get to it because they said it was like 6 centimeters deep. And she's so funny. She goes, I didn't know you had 6 centimeters of breast tissue. And I'm like, I know. Like, I guess it's like when you squeeze it, it's like 6 centimeters. So that was like one of the first things that was kind of funny about the whole thing. And then I got the results a couple of days later. And the way I figured out that I had DCIS was because this nurse practitioner that, you know, sees me for my, you know, just regular GYN exams, she had set up an appointment with this surgeon before she was able to call me and tell me. And I mean, it was all good intention. She wanted to make sure that I had a plan and I had an appointment right away. And then she was going to call me. But I guess what happened is when they made the appointment, it texted me that I had an appointment with this cancer surgeon.
Ooh, yes.
And I'm like, oh man. And she called me like profusely apologizing. But I mean, I totally understand why she did it that way. So it's not a big deal.
Right.
So.
But it does beg a point. I mean, we had this exact same conversation about a year ago with a young woman who was in her 40s, and she was actually a radiologist, and she was a breast radiologist. That was her subspecialty. And how, you know, navigating through the system is really difficult for everybody.
Right.
And then you add all of this other stuff where, you know, we use technology to text people, and then it gets away from you as soon as you put the referral in. It's off to this other thing that does whatever.
Yeah.
And it was, I mean, like, she literally walked down to pathology because she knew this pathologist, because she'd, you know, done tons and tons and tons of interventional, you know, breast biopsies. And she just walks in, and the guy was like the old sage, like the 70-year-old pathologist. He just looks at her and he goes, "You have cancer." And like, that's how she found out.
Yeah. And, you know, I guess, like, you know, going through it with my mom and just, I definitely, you know, I can see from the patient's perspective, like, I guess when you call somebody with, you know, that diagnosis, you really have to have a plan set up, you know, because, like, for the patient, just waiting on appointments, waiting on results, all that stuff is super stressful, you know, so.
Yeah. So from your perspective, you know, in the clinician's perspective, you get it. Whereas patients that aren't, if they're not medical, I mean, it's so devastating. I mean, I would say devastating to some people because, they're hurt, they're angry because, they haven't gotten the call from their doctor first. And then it's like, what's going on?
Well, and from our side, where we kind of run interference for, you know, multiple specialties, you know, especially in a rural area where people may have to travel, you know, an hour and a half to get to the subspecialty that they need for whatever kind of, you know, oncology they require. I always told them, Tom Petty's right. The waiting is the hardest part.
It is.
Uncertainty we can't deal with. Like
Yeah. No, for sure.
it just floored me how many times you'd give terrible news to a patient and they would be relieved because at least they knew what they had to fight.
Mm-hmm.
Yeah,
This idea
for
that
sure.
you're in limbo and maybe it's nothing, and maybe it's, years of treatment plus, maiming surgeries and all this, like that living in limbo, purgatory is not a fun place.
Absolutely. Absolutely. For sure. Yeah, so I picked this surgeon because I did not want to be the doctor. Like, and the surgeon, she just retired, but she kind of has the reputation like it's her way or the highway, and I was thinking about, like, so okay, so I've been practicing for 28 years, and so when I got breast cancer 3 years ago, I was thinking like there's no, there's all these choices, whether you have a mastectomy or a lumpectomy and radiation and blah blah blah. And I mean, you could sit there and think about, you know like I was, thinking, oh, okay, well, maybe I should do this, maybe I should do that. And I had a colleague who had DCIS, right, maybe a couple of years before I got it, and she was like insistent that she wanted to have a double mastectomy, and that was like what she wanted. And there's a lot of controversy. I think it's getting clearer that you should probably just have a lumpectomy if you have DCIS. But I was like, I didn't want to have to do all of that thinking. Like, I was thinking, when I see a patient, I'm like, to the point in my career, I'm not like my way or the highway, but I don't present all the options like they're all equal, because some options are better than others,
Right.
and so I was like, I really wanted this surgeon because I was like, I don't want to be the doctor. I want her to do the planning, and I'm just going to do what she says because she's been doing this every day for 35 years. So she knows better than I.
Yeah, and sometimes, I mean, in your situation and in our situation, if we know those professionals, we know their work, we have that faith that, yes, they're well-renowned, they can make the right choice. You still have the option to question in case something pops up. But you're right. You don't want to have to be the one making those minute decisions. And if you're like me, where you are a perfectionist and micromanage each decision, I mean, it's it's overwhelming.
Yeah, but that's how you ended up with me.
Oh gosh. Oh,
was that a TIA, a small stroke? Just for one second, a little rewind just for our non-medical listeners. DCIS, which is ductal carcinoma in situ.
Right.
Can you explain what that is compared to other types of breast cancer?
Sure. Yeah. So DCIS is kind of what they call like stage 0 breast cancer. So it is inside the duct, but it hasn't yet invaded outside of the duct, which would be like stage 1, or if it goes to the lymph node, then it's stage 2. I don't know my staging, but DCIS is breast cancer, but it is the earliest you can detect it, which is great. But you still have to go through basically what people, you either get surgery or you get less invasive surgery with radiation. So, and like it all, like, the choices all suck, and although it's very treatable, so that's a really good thing. But I was like, I just want somebody to tell me what to do who has a lot of experience with this, because I know, like, when I tell patients what to do, or when I do the shared decision making with my patients, I mean, I'm looking out for their best interests. And I feel like I can counsel patients well on different options and which options might be better for them. And I just needed somebody to do that for me. And I just like totally respected her because she's just a badass who did her, general surgery residency in the 80s.
Yes.
And she's a great surgeon, and people really like her. But like, I didn't need like although we are friends now, like I didn't need a friend. I needed a doctor. You know?
Right. No,
Yeah.
exactly. There are those people where, I mean, I have those. It's just like you don't need them to be your friend. You don't care about their bedside manner. And I've told some patients that ahead of time. It's like this physician is known for their skill. They're not going to be there to coddle you. That's
Right.
what, someone else, me, your families, but yes, and that happens.
Yeah.
So,
But it begs the most, I think, one of the most critical points in caring for somebody, especially in a professional level, and is trust. Okay,
Mhm.
so you picked this person because you had a pre-programmed trust for her skills and decision making because you knew those things, and it never ceases to amaze me how it always blew May's mind because, we'd done primary care for years, and then we've done about 10 or 12 years of urgent care. So you're meeting people, you're seeing, 4,000 patient encounters a year, and how little tiny things either build trust or break trust. And you don't have a therapeutic relationship without it. And so
Yeah.
we also encourage our non-medical listeners is if you're really unhappy with something with the provider, get
Yeah.
another opinion.
Yeah, for sure.
There's no
For sure.
reason to not do that so that you have
Right.
that trust, because that's critical,
mhm,
for everything, you know, going forward.
yeah.
Right. And I just kind of, to build off of that, since I was diagnosed, when I have patients that are diagnosed, especially with DCIS, because there's some controversy, there's a lot of different options you can go with. Sometimes I would recommend my surgeon, and sometimes I wouldn't, because I can just, I know my patients pretty well. And I think my personality was that I, needed somebody like my surgeon.
Right.
But I think other people might be kind of turned off by her. And it's funny because, so I have one child, I have a son, and when I was pregnant with him, I chose this guy in my practice who I he was like the best surgeon, and I chose him because I couldn't push him around. You know what I mean?
That's
Like,
funny.
and I ended up having a C-section, as I knew I would, and so I kind of, and I guess he wasn't considered to be maybe like super good bedside manner. I mean, he was kind of old school. He's about 20 years older than me, but we're like great friends now too, but
Mhm.
I needed a skilled person who I didn't need a buddy for
Right.
my OB doctor. I needed a doctor, so, yeah. So, and although he is my buddy now and
Right.
has
And
been for a long
you know,
time.
it's fascinating because May and I have taught countless residents, and it's fascinating because medical training, at least, seems to be swinging to this very much looser kind of, paternalism is bad, et cetera, et cetera. And I would, look, we started training in the 80s, and that was starting to go away. But the fact is that it's paternalism or maternalism, as the case may be, because now we're
Yeah.
graduating more female physicians than male
Right.
physicians. Uh, it is actually a tool that
Yeah.
that can be used really effectively. You just have to know how to use the tool. And
Right.
just like when you reach into a toolkit, everything isn't a nail, so
Right.
everything doesn't require a hammer.
Right.
Sometimes it requires more finesse. Sometimes it requires a certain sized wrench, et cetera, et cetera. And I would explain that to my students. I'm like, there's certain people, a 17-year-old scared, witless, 38-week pregnant woman with pregnancy-induced hypertension
Yeah.
needs a mother or a father to take care
Yeah.
of her.
For sure. For sure.
Doesn't need shared decision making.
Yeah.
Oh,
Yeah.
right.
And so I love how you're kind of illustrating this both in your own life and your patients' lives, because ultimately what really matters is the outcome, right?
Yeah. And it's
Exactly.
funny because I have been a board examiner for the American Board of OBGYN for like 15 years, and I like it because it teaches me, I mean, different things, you know, as an examiner, but definitely like a buzzword over the last couple of years has been shared decision making.
I
And
know.
I understand, you know, why that is important. But like to give you another example, so my mom is 77 and she has a new internist, and she was telling me like, and my internist said, well, what do you think of this? And she goes, I mean, what am I supposed to say? I'm not a doctor. Just tell me what to, you know, so I think you're right. Like, and I think as a physician, you can kind of get the impression when you're talking to a patient, and especially if you've known the patient for a while, like, yeah, there are some people who really want that autonomy and want shared decision making. And then there's some people that are kind of overwhelmed, or they really want your opinion. They want you to make the decision. So,
That's
um,
why, right, when you hire a professional, I mean,
yeah,
it's almost like with that shared decision making, it's like we're offing the decision making to the patient,
yeah,
which is unfair because
yeah,
they
yeah.
don't. So my bias is it's getting too heavy that way, and sometimes, yeah, we just need to take the reins and make the not make the decision for them, but it's like, yeah, this is the best choice. If you can't figure it out, this
Yeah,
is
and
the best choice. Yeah.
I think sometimes, like, also, like, with doctors as patients, sometimes maybe the provider wants to, you know, respect you and, "Oh, what do you think?" You know, and I'm just like, "I don't wanna think. I just want you to tell me what
Yes.
to do." But anyway, so that's why I picked my surgeon, that's why I picked my OB, and, you know, I'm super happy about the decision.
No, I'm with you. I totally echo those same things because when I'm in there as the patient, I mean, I can Google stuff, like I said, and look things up that I don't know till the end of time. But I'm like, I'm not trained in this, so please tell me what you say as a professional, as my friend and a colleague and a professional. What should I do? And if
Yeah,
I really don't like it, I'll say, no, that's not an option. But sometimes
yeah,
it's like, please just pick the choice. Yes.
yeah.
Um, so so you're now at the point where you're going to see the specialist.
Yep.
Um, and let's pick it up from there. So what happens when you
So,
walk in and the
yeah,
plan? Yeah.
so I was diagnosed at the end of February 2019, and I saw my surgeon. Can I say my surgeon's name? I'm sure she wouldn't mind,
It's
or
totally
maybe I.
your call.
Yeah, I mean, she's awesome. This I saw Claire Carmen in March,
Mm-hmm.
and we had a spring break trip planned, and I was like, "Can I? You know, I don't want to cancel these reservations. Can I go on the spring?" And she's like, "Absolutely." You know, so then she set me up for surgery in April of 2019. And she does surgery at my hospital, and she was asking me like, do you want me to operate on you at this other hospital, you know, because you work at Centera, Norfolk General? And I'm like, no, I want you to be in the OR that you're normally in, with the team you're normally with. Don't change anything. You know, I want you to be doing what you have done for 35 years, you know?
Right.
Um, so I had surgery at Norfolk General, and I actually ended up having surgery in the operating room that I operate in with the team, like with the nursing team that I don't do that much surgery anymore because I mainly research, but it was the nurses that I know, it was the techs that I know, and I don't know, maybe people would be like, think that's kind of, they wouldn't like that, but I was like, I'm in good hands, you know. I was really happy that I was with the team that I knew.
You know,
I,
May and I have, as I like to say, I go to the orthopedic surgeon more than I go to the dentist, and that unfortunately is not an exaggeration. And I actually have learned a real appreciation. I've had a couple, you know, hospital experiences with people that I've worked with for decades, and I found it really amazing because it's actually easier to take for granted people you work with because they're colleagues, whether it's a nurse colleague, whether it's a medical assistant or a surgeon or whatever. And when you see people actually be professional in their professional role,
Yeah,
and they're just
yeah,
doing what they normally do, I learned so much more respect
yeah,
for
I
these people
agree.
that I already respected. But I was like,
right.
man, they are top notch.
Yeah.
You know,
Right.
I agree.
And
I know
oh, go
that
ahead.
there's some friends, colleagues that don't like it. It's like, heck no, I'm going somewhere else because I want the autonomy, and I don't. And
Yeah.
then there are other people that don't mind it at all because of just exactly what we said. It's like there's that comfort thing, you know, and you have the trust, and
Yeah.
it's okay. Yeah.
And just a couple of funny stories about the pre-op period. So I guess now they test everybody for BRCA, and then there are some lab companies that are doing these additional cancer screening, tests. But so I got screened for BRCA 1 and 2, and as you know, if you're positive, you need a mastectomy, and then you need your tubes and ovaries removed. Like Angelina Jolie is the uh, famous person that did that. But so anyway, so I'm waiting on my BRCA testing. It was negative, which was great. But so there's a guy, one of my colleagues here at Eastern Virginia Med School. We went to medical school together in 1990. We did residency together in 1994, and we're working together now. So I've known him for over like 30 years, and he's one of like the senior most GYN surgeons here, right? And I was kidding him. I was like, Steve, if I am BRCA positive, I want you to do my hysterectomy, but you're not allowed to look down there. Like, no looking. Have the residents put all the stuff, and he was just like, "Oh my God, you're killing me."
That's awesome. That's funny.
Well, and it is weird for our non-medical listeners because I ended up, small town, right? And you become friends with people, and they trust you. So then they want you to do their OBGYN care. And the thing is that
or not.
Yeah. But I mean, I delivered tons of people that we went to church with, and now we go to funerals, and there's the 25-year-old kid that's the grandson of somebody that just passed away. It's just kind of this weird circle of life kind of thing. But it is, I mean, it's just like when it's medicine and you're in a professional environment, like it just it's just a different world. I mean,
yeah. And I mean, had I been BRCA positive, I would have totally wanted my buddy to do my hysterectomy. But, I mean, he's, I don't know. I mean, we've just known each other for so long and I was kind of razzing him. But fortunately I did not need his services. And then the other funny thing that happened, on the day of my surgery, actually, I'm in, the holding area of the OR, and I'm thinking, okay, I'm having a lumpectomy. So, I wonder if they're going to cath me in the OR or if they're going to put a Foley in, because it's a pretty quick procedure, right? So I didn't know whether to take my underwear off or not. I mean, so obviously if you're having a GYN procedure, you take your underwear off. Okay.
Right.
But I was like, oh my God, should I take my underwear off or not? And I was like, if I'm not supposed to take my underwear off and I take it off, then they'll be like, wow, Dr. Thurman's, So I was like really torn what to do. And so like the tech that put in my IV, I was like, do I need to take my underwear off? And she's, oh no, you don't need to, and I'm like, okay. But I was thinking like, boy, they have to really specify that, so.
See, even the gynecologist doesn't know if she needs to remove the underwear. See, so patients don't need to feel embarrassed.
But I would think a gynecologist would just divert to underwear always off.
Yeah, right. I know. But then, I was like, gosh, I mean, if I don't have to take my underwear off, I probably shouldn't. And I know all these people.
I'm going to Oil Can Henry's to get my oil changed. Underwear on, underwear off.
So, so that was, so then I had a lumpectomy, and then I also had I actually had a lumpectomy on both sides because I had DCIS on the one side, and I had calcifications on the other side, but they didn't biopsy those. They did a lumpectomy. I think, I can't remember why, but I had like atypical ductal hyperplasia on the other side. So I got two lumpectomies basically. And then I have terrible migraines. So when I came out of surgery, I was fine, but I just had this raging headache. I mean, I was just, oh my God. And this lady, one of the post-op nurses, gave me like some ginger ale. And I was just like, you are my favorite person in the world. It was like the best thing ever, you know? And I've been over to the OR several times since. And whenever I see her, I'm like, oh my God, you were like my guardian angel that day, you know?
I can totally relate. Yeah, I'm the same
Yeah.
boat as you. I'm like one of the
Oh,
worst migrainers, and I've had them forever. And yeah, OR surgeries, not
oh,
all, but depending what
you're
they do.
dehydrated
Yeah,
and oh,
and it depends on the pre-med. If they give you narcotics, then it's game over. And isn't it amazing the little things though that make such a
yes.
huge
Oh my
difference? Like,
God.
yes.
Huge, you know, and I think like as a doc, you know, usually you drop your patient off in the post-op area and you go talk to their family, you go do your next surgery or whatever. And so you just don't really get a sense of all of the important things that they're doing there, which, so that was nice. And I had my surgery on a Tuesday in April, and I was supposed to go back to work not the following Tuesday, but the following Thursday. So I was supposed to have like a little more than a week off, which was totally reasonable. But then I found out that she it, she didn't get everything on the first go round, right? And and actually, I remember like after I had the first lumpectomy, I was pretty stressed that like what if they find cancer in there, and so that waiting, I had the first surgery on a Tuesday and I didn't get my results until Friday, and that was like it was just stressful. I mean, I thought things were going to be okay, but it's just in the back of your mind always there, and so that was stressful. And then I think it was a low when she called me on Friday and said that she didn't get everything. And like she told me that there was like a 15% chance that we have to go back to the OR. And like I understand it's not a mass, it's these little calcifications and you may not get everything. So I actually had to have a second surgery the following Tuesday, and she got everything that time. And she actually, I was looking at the pathology report, and she got like some pectoralis fascia. And I'm like, holy cow, but so I was supposed to go back to work the Thursday after my second surgery, but I ended up going back like the Monday after that. And I think it was I think it was too early. I should have taken some more time off, and I could have. I mean, I have paid sick leave because I was like going into work. I was sleeping with like ice packs on my breasts and coming into work with an ice pack, and that was just stupid. I should have taken more time off.
Isn't it amazing though? I think that's a frequent thing in health caregivers and docs. We just suck it up and we're like, I can I can push past this. I've
Yeah,
done that after various orthopedic things, even with my migraines. And maybe maybe it's not just doctors. I think there's some people who it's that personality type where it's like I got to tough it up and
but I
take one for the team.
I think going through residency in the 80s or at least up to the mid 90s, you get trained that way. Like there's I don't know how many times I went to work. I don't think I was unsafe by any means.
oh, yeah.
But, I was up all night, delivered a baby, had to spend 3 or 4 hours bagging this, newborn, waiting, for an hour and a half transport to come and take the baby to the NICU in Portland. And then, you sleep for maybe an hour and a half or 2 hours. You're totally adrenaline out. And then I go see 35 patients the next day.
Oh my God, yeah.
I mean, that's just like when you think of it.
And you worked all day through your appendix before it ruptured. I mean, things like that. So I think
they took it out and I took 4 days off.
Yeah.
Like, I mean, it's just like, I look back and it's just like stupid. Right.
Yeah. We're not, now he's not calling you stupid, but
No,
I think
I'm
there's
calling
a common
myself
thing.
stupid.
There's a common
but
thing.
it is. And part of the reason why I went back to work when I did, which was, less than a week after my second surgery, was because my research group, we had just completed a study that we knew that the sponsor, who's a large sponsor of our work, was going to use our data for a supplemental NDA application, which means you're going to get audited by the FDA, right? And so this study was done at our center and then 2 other centers, but we knew our center would be audited. So I think like shortly after I came back, we had a lady come in, to kind of prep us for the FDA audit. And like one of my colleagues, a couple of years prior, we had an FDA audit and we had a prep and everything, but he got like a few citations and it was just super stressful getting those citations and responding to them. And I was like the local site investigator for Conrad. And I just felt like it was important for me to be part of that training and for me to, be in charge of the team or whatever. And so that's, I came back. It was very shortly after I got back that, we had this training. And then I started radiation treatment. Oh, and when I first went over to meet the radiation oncologist, one of my patients, who's been my patient for like 10 years, I didn't realize that she was like the head nurse of that unit. I knew that she was a nurse at Centera, but I didn't know where. And so that was really cool. Like when I went in there, she's like, Annie, but so I was getting radiation and we had this unannounced FDA audit, which I don't know why they do that, like what if I had not been here or whatever. But so we had a 5-day FDA audit in May of 2019. And like, while this auditor, who was super nice, while she was here, I was like popping over to Centera every day to get radiation. And so I kind of used that again. And we did awesome on the FDA audit. We didn't have any citations. It went very smoothly. But I always am like, kind of like razz my boss, like, yeah, I was getting my boob radiated while we were getting audited. So don't question my like loyalty.
No
Right.
kidding.
But anyone that knows anything about clinical research, especially when you only have a handful of sites,
Yeah.
and then you're at the NDA level, which is a new drug application. I mean,
Right.
this is like once in a lifetime kind of opportunity, and if
Yeah.
it blows up,
Yeah.
you lose funding or it doesn't. I mean,
Yes.
like it's a very high stakes game, and I
It really is. And
Yeah.
like our future funding, so this was in 2019, and we were going for some future funding with this company and with USAID, and we have gotten it. But yeah, I mean, performing well on this FDA audit so that this company could use our data for their NDA, it was super, super important. And so, I just felt like I needed to, be present for that. So I was, and it went fine. But I just remember, and we had like some people come down from our DC office, and I just remember like coming into work with, an ice pack on my breast, and then you put that Aquaphor stuff on your skin when you're getting radiation. And I remember like going out one night with the team, and we were watching the Capitals play in the Stanley Cup playoffs, and I think they won that year. And like my Aquaphor had like gotten on my shirt. It's just like, oh my god, just that kind of sucked. But and I also was thinking, like I had to get 21 rounds of radiation, and I mean, literally, it was like I would walk like 5 minutes over to the radiation place on campus. They give you this little barcode so you can check in really quickly. And the actual treatment, I mean, probably 95% of my visits, I was in and out within, 20 minutes. I mean, it takes a couple of I think it takes less than a minute to actually get the radiation, but like all of the stuff, walking over, changing, whatever, it would take not that much time. And the techs over there were awesome. Every once in a while there would be, a really long wait, but it would be because, they had an emergency, or I didn't realize this, but they do radiation in children, they were doing radiation in kids. And it was just like, I mean, when you're sitting there getting radiation for DCIS, and everybody else that's getting radiation is getting it for like head and neck cancer, and just, I mean, I I remember thinking like, it's a good thing that DCIS is so treatable, because I just can't imagine going through radiation and just having a really terrible prognosis. I mean, my God, I just felt for those people.
But even a good prognosis, like I'm a big heavy metal person, and
Oh,
you know,
Eddie Van Halen.
yeah, a little, but even harder. Yeah, well, but Eddie Van Halen, Bruce Dickinson, and Dave Mustaine. So Megadeth, Van Halen, and Iron Maiden, the all had male throat cancer,
Right.
or head and neck cancer.
Yeah.
From HPV, which is, I mean, I want to get an expert and do an entire episode on that, because that is so bizarre how men do not make a immune response to oral HPV, but women do. Like, it's so
Yes.
it's so weird.
I know a doc who had throat cancer from HPV. I'll have to give you his name so that you can interview him for your
that
show.
That would be great. But I actually, I've read a couple of the autobiographies of these guys, and I went to see Bruce Dickinson do his just speaking tour. And it's like, okay, you sing for a living. That's what you do. I mean, that is the moneymaker.
Yeah.
He diagnosed himself on Google because he's a polymathic genius. And then to talk about the therapy, they go, yeah, we have an 85+% chance that will essentially cure you. We don't know, how long it stays, but we can treat this. It's very treatable. We got it at a treatable time, et cetera, et cetera. But the treatment was like a year of being tortured. I mean, the guy was thin already, and he still lost like 35 or 40 pounds.
Yeah, man.
And you can't swallow, and your throat is chronically on fire. You can't sleep. You can barely swallow your own spit. And I'm like, my God. And that's a good prognosis.
Yeah, no, for sure. I mean, I just remember seeing, these people that were doing the head and neck radiation, and then the lung cancer people do radiation. And I just remember thinking like, I mean, what I'm going through sucks, but it does. I mean, what they're going through is so much worse, really, Oh my God.
Yeah, it's perspective, which sometimes is, the things that keep us humble and keep us going. And
yeah,
and like you mentioned before we started recording, it makes us better doctors.
Yeah, for sure, for sure. And then the last day of my radiation. So I have been in charge of resident research here for like 13 years. And I was in charge of it at some previous institutions that I've been at. But so we had resident research day in like June of 2019. And I invited a very good friend, colleague of mine, to be like the guest speaker and the guest judge and everything. And so we did resident research, and it's a lot of work, that day. And we went out to dinner the night before, and it was great. And then the next day we had resident research, and I went right after for like my last radiation treatment, so like,
yeah,
it was a long day, but
it's hard. I mean, you're in that, and it's like you're juggling two lives almost,
Yeah,
or three, or however.
are.
It's like I'm having my secret life as a patient. Well, not secret, but you know what I mean? There's that life.
No, for sure.
And then trying to keep normalcy in your life and do the other things that we keep doing. Yeah.
Yeah.
So you had.
Oh,
go ahead.
I probably, I was thinking like, I took about 2 weeks off for the surgery. I definitely should have taken longer off. And I mean, radiation is, I mean, I didn't need to take 21 days off for that. I probably ended up taking 30 hours of FMLA off for that, but I wish I would have taken maybe a half day or something. It's just like to pop over, get radiation, and then just keep working is just, I don't know. It was dumb, but anyway, but I did it.
So I assume everything's going well now.
Yeah, yeah. Oh, so I'm trying to think if there's other funny things. Well, so now I take tamoxifen, right? And for a while, our group was looking, well, I thought this was a terrible idea, but my boss thought it was a good idea of using tamoxifen in young women to treat some side effects of like contraceptive side effects, right?
Mm-hmm.
And so we're like in this meeting, and I'm like, oh yeah, great. Let's tell the teenager, like, hey, you can take the same medicine that I'm taking.
That's right.
Like,
Do you want some chemotherapy?
right. So, but I feel like, now when I see patients and I tell them, hey, you definitely need to get your mammogram. I had breast cancer in 2019 and it sucked, but at least I got it detected really early and it was very treatable. And I feel like also, like I have a lot of, I'm 54 now. I'm going to be on tamoxifen for 10 years, and there's a lot of side effects from tamoxifen. And um, I I was telling somebody the other day, like, so when I started as an OBGYN, I was 30 and I was single, and I think I thought I knew everything, right? And these like menopausal ladies would tell me these symptoms, and I was like, I just couldn't believe it. I mean, I don't know. I just like, I hadn't
Yes.
experienced it, so I didn't really understand. And so now, um, I really like treating menopausal women because I can like super relate to all of these symptoms.
Right. I mean, obviously as a human being, we're kind of the patient through some normal aspects of life,
Yeah,
childbirth. It
right.
was hard to relate to patients when they had a baby because I'd never, when I didn't have one.
Yeah,
After I had my own kids, I was like, well, this is easy because I've gone through not easy. Well, yeah, I would say a lot of things were totally different because you had
yeah,
your own kid. You could relate. Same with different stages of life and menopause being one of them. Because I was the same as you. I'd be like, man, some of these women are such whiners with this stuff. Like, how bad can it be? And I had a
right,
really tough mother and mothers who never
right.
seemed to flinch with that stuff. And so I listened to some of these women. I'm like, oh man. And then of course
Yeah,
I
but
ended up being one of the worst severe menopausal cases ever. And I'm like, this is ridiculous.
but they had the secret formula, which was vodka and cigarettes.
Yeah.
Yeah, that's true. Yeah, for
Oh,
sure. And speaking of like, just understanding childbirth. So when I got out of residency, I was 30, and I went to Japan right from Bethesda, and it was myself and then these two other guys were the OB department at Naval Hospital Yokosuka, Japan. And the two other guys, they were both right out of residency also, and they were not married. They didn't have kids. So like, people are asking, yeah, obviously people are asking us as OBs, about breastfeeding and all this stuff, and we're like, we have no idea. We're like, hey man, once we deliver the baby, you're on your own.
that's right.
That's exactly.
Next specialist, please.
Talk,
Once the
talk to
pants
your
are back
pediatrician.
on, Elvis has left the
Yes,
building.
exactly.
But yeah, I mean, I guess, just through life experiences and being a parent, being a mom, I don't know, having gone through breast cancer, I definitely think it makes me enjoy my patients because I can really understand, um, what they're talking about. And so, and I guess, I mean, I think the longer you practice medicine, the more enjoyable it gets. And also like when I was in the military and when I was moving around because of my husband's job, you didn't know your patients for as long. And now I have been here for 13 years. So it's just easier because I know a lot about medicine now that I've been practicing so long, and I know my patients, and I've been through, breast cancer. So I think that was the good thing about it. Um, I, I don't know I guess my biggest low was when I found out I had to go back to the OR. That sucked. But and now it's like I forget sometimes that I had to have that, done. But um and
What's the biggest takeaway?
I think the biggest takeaway is kind of, these little moments in patient care, which are not necessarily done by the doctor, but done by the techs, like, hey, take your underwear off, and, and like the radiation techs. I think those are like, that is what, caring and delivering care and taking care of people. So I think that doctors don't often see all of that stuff until they're a patient. And I hope that I'm, giving a little bit more personalized care. And I hope that I'm a little more tuned in to some of the things that women think about, particularly after breast cancer. So it's made me um, more grateful of the resources that I had, the support that I had, the people that helped me through it.
Yeah.
And I also, I remember, so my husband got out of the Air Force. He retired from the Air Force in 2017. So we went on TRICARE, and I was so worried about like the insurance support, because we had always been with the military where you never got a bill or whatever. And so there were a couple of times, like I got a bill from radiation for like, $65,000. And I'm looking on my like Humana website, and it was like, no, you owe, $150. And so I was like, God, what are the, for women that are going through this and don't have insurance and have to be super worried about, is this going to bankrupt me, which it would. I mean, so that I was very thankful that I had, TRICARE, and that I really didn't have any problems with that. But
yeah, it opens your eyes to a lot of things if you aren't already aware of that when you're a patient, is the financial aspect. I know some people face hurdles just even navigating their own insurance systems and getting authorization.
But the systems can't navigate this.
Yeah.
I mean,
true.
I used to sit on the parent board of a, 5-hospital, 275 doc, regional healthcare delivery system. And I went to the CFO and I showed him a bill and I said, why would I pay this? It just says service, pay this bill.
Yeah.
Other service, pay this. It's not itemized. It's not, it doesn't say what it was for. Was it for a knee surgery? Was it for an ER visit? Was it for an aspirin? It doesn't say. I said, if you went to a mechanic and you got a statement like this, you would be insane to pay it. And he looked at me and he goes, well, that's the standard in the industry. We can't itemize them. And I'm like, well, then expect people not to pay you.
Yeah.
It's crazy.
Yeah. I remember like when we were on vacation before I had my surgery, there were like a couple of things on the news about people who, they delivered a baby and their obstetrician was in network, but the anesthesiologist was not, right? So they get this huge bill from an out of network anesthesiologist. And so I remember when we were on vacation, when I was preparing for my surgeries, I called the anesthesia department, and I'm like, does every provider in the department, take TRICARE? Because I was like, I don't want to get, a $20,000, $10,000 bill because I happen to get the one guy who, isn't credentialed with, I don't know. I mean, I just know what I see on television, so that was, all of the financial stuff. And I have a lot of resources and I have insurance, and I know who to talk to, in a medical system. It was still, I think, stressful, and I cannot imagine how stressful it would be for someone who doesn't have the resources that I have, so
That
I'm
is the
thankful for that.
story we have heard
Yep.
every single time we've talked to somebody who is a physician, even
Yep.
treated at their own hospital, having to navigate the system itself. I mean,
Yeah.
it almost the tinfoil hat side of me goes, it almost seems intentional, because it's just it's
Yeah.
like, it wouldn't be hard to fix that,
Yeah. Yeah. It seems so dumb. And I will tell you the other thing that, when the lady that helped with my biopsy, like she was going to PA school, and she not necessarily a letter of recommendation, but like patient perspective. So I wrote a letter for her as part of her application. And I remember, all the hospital ever hears is, complaints. And so after I had, my biopsy and whatever, I sent in a thing to Centera, like just saying how well they took care of me, and the radiologist is a retired military guy, and he goes, "Hey, thanks for putting in a good word." And I'm like, "Yeah, it's not going to get you a raise or any time off, but you always hear from patients about complaints, and nobody ever takes the time, to thank. Just the little, like I said before, just the little things are super important when you're, just in a vulnerable, scary situation. I was very grateful that I had a lot of support and good people taking care of me.
Yeah, it's
So,
interesting, because the themes we've had from talking to other physicians that have been patients, and then of course ourselves being patients. Myself, it's overwhelmingly positive as far as the professionalism of our colleagues.
yeah,
That's the one thing, and it's overwhelmingly negative, and consistently so, with regards to navigating the financial system of healthcare.
yeah,
Like,
yeah,
those are like pillars.
yeah,
Very
for
good
sure.
care, very professional, state of the art. Trying to navigate how it gets paid for, complete and absolute total disaster.
Yeah, and I mean, I didn't have any disasters. I mean, I remember like when they sent me this bill for like tens of thousands of dollars from radiation oncology, I called the line and I'm like, "Hey, my website says this," and they didn't argue. "Oh yeah, that's okay." And I'm like, "Oh my God, like do people get these bills and think they have to pay this much money even if they
Mhm.
have insurance?" So I think that was the worst part. But yeah, it's just that is stressful. And I'm looking around the waiting room at radiation, and I'm thinking, man, I hope all of these people don't get that bill, because they may not know to look on the internet at what they actually owe, or they may not have insurance, and so yeah, so that was stressful.
Well,
So
we are happy that you shared your story with us, and we're
yeah.
awesome that it's ended in a positive note and things are going well. And thanks for being here and um, just sharing what you've gone through, and the positive, the negative, and the fun, and the things we can laugh at. That's
Yeah,
I
I'm
think the
I'm
thing
really
for me is,
into
if you
like,
can keep a positive attitude and learn to laugh at some of the things. I mean, not always when you're going through it, right? But it really makes
yeah.
things easier.
Yeah, and
So
I'm also, I mean, like I've been married 20 years, and just I don't know, they were like, I think, having my husband's support and stuff has been really really important. So I'm grateful.
absolutely. Well, thanks again.
Yeah, thank you.
Great meeting you and having you on.
Yeah.
And we know our listeners are going to love hearing your story.
Well, that was great. Isn't it awesome to talk to somebody that's positive through everything? I mean, she never really talked about, oh my goodness, this is the worst thing ever. She was like, oh, we'll just do the next thing and we'll get through it. And she did. And, she still has a very successful career. And
I mean, everybody faces trials and hard times differently. I mean, it's definitely what you say, it's refreshing to hear her have a great attitude throughout. It doesn't mean if you have a bad attitude when you're going through something hard like that, that you're a bad person. But I think it's just great to hear her talk about it now, can kind of joke about things. I mean, even making light of the fact that there she was in the OR where her team usually takes care of her, and freaking out about the catheter and things like that. It's the kind of first thing I would think of too. But it's just refreshing to talk with someone that is got a good attitude and is still doing medicine with a positive spirit, and that's what I like to hear.
Well, and a bigger perspective. I mean, being a patient just a few times myself, it really, as we said in the interview, I've always been struck by the professionalism of my colleagues, whether or not they were other physicians, whether they were, nurses, x-ray techs. It's really, it really makes you proud.
Well, yeah, because you get a chance to actually sit back and observe them from different eyes as the patient, instead of just as colleagues, and you're like really paying attention to what they're doing, and you're like, oh wow. And
then when they wheel in the the PCA morphine pump, that wasn't bad either. I had that once. That was kind of wild. And then you realize how horrible it is after a day and a half of being on that. It's like, get everything out of me. I want to just have a normal brain and not be groggy anymore.
All right. We hope you enjoyed that episode, and we've got more of those coming up soon. So stay tuned and give us a shout out, give us a like, check us out on social media, and we hope to see you soon.
Absolutely.
See you next time.
It's no secret that medicine is a bit, uptight. That's why Tim and I created BS Free MD, to mix things up a little and have fun in the process. Besides, we are having these exact same discussions all the time, so we thought we might as well invite everyone to the party. If you really like us, you can get plenty more, and maybe see one of Tim's cool tattoos on our Instagram or Facebook pages at BS Free MD. See you next time.
But we try to keep BS Free MD as raw and real as possible. We can't be held responsible for any medical decisions or discussions had as a result of what you've heard on the show. We know, bummer. But the truth is, we really do care about your questions. So feel free to reach out to us by email at doc@bsfreemd.com.